So we're going to get started with our students and young professionals session here. Before we get started, for those of you that are on Zoom, could you tell me with a thumbs up or type in the chat, are you able to hear me? Yes, no? Let's see. Yes, wonderful. Those that are with us virtually can hear me. So hello, everyone. Those that are here in person, hello, everybody online. We're going to be starting the students and young professional session here today, starting a little bit late because our program is running a little late, but let's see if we can make it through on time. So I am one of the hosts. My name is Oscar Blanco. I am one of the researchers here on campus. I teach in health informatics. Hello, hello, welcome. I'm involved in the health informatics program, digital health program, global public health to differing degrees. I do research here specialized on digital health literacy for improving healthcare access. The other host, Professor Muzi Ge, is unfortunately not here with us. Hopefully he'll be joining us a little bit later. But when he joins us, he can introduce himself. So the purpose of today's session is to highlight a little bit of the work that we have from students and young professionals is what this session is designed to do. To give a little bit of an idea for students to see what kind of work you can come up with by the time you finish your studies, whether it's at the bachelor or the master's level. And for those that are maybe not students but are interested in this work, early researchers or early professionals fits within this category. So as far as our speakers today, or our presenters rather, we've got a list of 5 presentations for you today. The first one that I have on my schedule is from Charles Ume. Let's see, Charles, are you with us here virtually? Let me take a look. Charles, if you're here, turn on your microphone. I'm not sure what the name looks like in Zoom. Looks like he is not here right now, unfortunately. Then let me mark that off here. Just one moment. Okay. Then we'll move to the second one. Let's see if he's here. Elvis, are you with us here today?
Yeah, I'm here.
There we go. Let me just adjust the volume here. In one moment. Here's what I'll do. I will give you, let's see if I...
Okay, perfect. I will just go ahead. So good morning, colleagues. Good morning, friends. Good morning, everyone that's joining from anywhere. My name is Elvis. I'm a graduate of this prestigious program, Medical Informatics. And my research today, I will be presenting on the evaluation of doctors' perspective towards the use of digital health technologies for the management of sickle cell disease. All protocols fully observed. My presentation is going to cover this outline. And here we go. So I want us to take a close look at this picture and the people there. You can see all smiles in their faces, happy people. These are all people living with sickle cell disease. But one thing you may not know, as they are happy, so they are also facing difficult challenges in their lives. They struggle each day to wake up. Every day they wake up from their bed is a struggle, to catch up with daily activities like others. And then they pass through difficult complications daily in their lives. So that's why we are doing this research. So first of all, what is sickle cell disease? It's a multisystemic genetic disorder that affects the shape of the red blood cells and their functionality. And once this happens, it results to several symptoms just such as jaundice, frequent infection, anemia, delayed puberty, ulcer, different type of symptoms. But the hallmark of this disease is the crisis, pain crisis, like most people call it. So they have pains in most of their joints, in their chests, due to different type of complications in their body systems. And these complications can affect definitely, or let's say, put it all together, most organ systems in the body. So, I mean, if you are in their position, you will see that every day of their life is somehow a struggle because it affects virtually all forms or all organ systems. And because of this, they need multi-care systemic, or they need multi-care from different practitioners. They have to see daily, they have to see practitioners from time to time, let's say monthly or even more than once in a month. And when they come with different symptoms, they can also be faced with all these complications, as you can see. And because of this, they need comprehensive care. And when we talk about comprehensive care, we mean that a form of care in such a way that different professionals partake in their care. And if you're coming from a less privileged or less developed world, you know that insurances are nowhere to go about and accessing care is very difficult. So this is already a huge burden onto them. Moving forward, what is the problem in this disease is that it affects about 25 million people globally, and is majorly found in sub-Saharan Africa, in the Mediterranean region, in India, Middle East, as well as some parts of America, even here in Germany. And the global prevalence is more than 300,000 a year. Funny enough, about a quarter or third of this is much populated in sub-Saharan Africa, with Nigeria as a major zone or hub for this disease. 150,000 deaths per year, and about 100 of them die before the age of 5. So we can see that this is a huge problem. If we go back dates to 1979, when Monolux and his colleagues carried out a study on this disease, it was found that it was a huge burden of concern as at then. And they predicted that if nothing is being done about it, it's going to cause a huge problem today. Funny enough, it's the problem, what they predicted is coming to pass. So our research setting, which is Nigeria, which is our focus, has problems too for this disease. And you can see that looking at the doctor to patient ratio, we have just 1:25,000 as against 1:600 recommended by WHO. Look at the population. So the difficulty here is that the manpower of the healthcare system is already short, and we see doctors leaving the country every day. Not just anyhow doctors take care of these patients, but we have specialists, which are hematologists, that take care of blood diseases. They are also in shortage. Then there's lack of comprehensive care programs for this set of people, as well as inequitable medicines, innovative tools, financial resources are, hampered. All these difficulties and burdens are what these people are facing. But now I ask myself, how can digital technologies help? We've seen that digital technologies has helped in different chronic diseases like diabetes, and I told myself, can this also help for this set of patients, for the fact that they can access healthcare because of the cost in it? We can see that telemedicine has provided several solutions, for people in such resource poor settings. And the WHO in their 2020 global strategy, they predicted and they gave a recommendation that digital health technologies can be used as an enabler. IT, the International Telecommunication Union also gave this recommendation. But however, several studies have been done to prove that digital health technologies can be used for improving health outcome of patients in sub-Saharan Africa. But funny enough, most of these studies are not in Africa, talk less of Nigeria. That's why this research came into play. And for our knowledge, from my knowledge, it's one of the researches that have covered this area, or the only research that have covered this area. That's why the main goal of this research was to evaluate the kind of digital technologies that physicians use, if there is anyone at all. And if there's anyone, is there satisfaction from using these devices? Then if there's none, how do they perceive use of these technologies to cater for or improve the health outcome of people living with sickle cell disease? To this instance, then I now have, 3 goals, to accomplish for me to be able to, prove this, my hypothesis. First of all, was to conduct an in-depth literature search to see if any research has been done already. Like I mentioned before, none was found. The little ones that were found were very porous and they didn't really cover a huge population. Then the second step was conducting a cross-sectional survey, which was one-on-one interview with doctors or hematologists. And then the goal of this was to determine their knowledge, first of all, of the use of digital health technologies. And if they know about this, are there any ones they are using to cater for those living with sickle cell disease? And if there's none, would they be willing to recommend it, for use in managing sickle cell disease? Moving forward, this is the step that was used to do my literature research. So we use databases like PubMed, ScienceDirect, Google Scholar. So when I use this search key terms, telemedicine, digital health. It gave me 92 publications. These publications were perused, the abstracts were perused to see the similarities of our research goals or questions. And now for me to be able to get, a focused study, I used or iterated it with Africa and Nigeria. And funny enough, like I mentioned before, nothing was found. Therefore, it now led me to now go into a scoping review of checking different websites, university publications, or databases to see if we can get more research on this. And at the end of it all, like I said, I just saw very few of these researches that were, or studies that have been done. Among all these, including the ones that I saw earlier globally, I narrowed down my research to just 5 publications, which helped in this study, from where insights were gotten. Moving forward, my research was basically qualitative study, and it was kind of a one-on-one interview with experts, that's hematologists and residents as well. Then it was transcribed. After the interview, it was transcribed verbatim. It was transcribed verbatim using MS Word as well as manual transcription. Then the Quecos quality data analysis software was used for data management as well as for analysis. After we got this, after I analyzed the data extracts, I now mapped them to the thematic analysis framework, to the technology acceptance framework, to be able to get themes from these interviews. And the sampling method was simply purposive. It was non-probability sampling. And then most of the doctors, how they were recruited was from different sickle cell clinics or healthcare institutions in Nigeria via snowballing, phone calls, and WhatsApp broadcasts through hematology groups. Moving forward, like I said, I used the technology acceptance model, which was simply, if you want to devise a technology tool or digital device for management of diseases, this is kind of a framework that has been used by several researchers in the healthcare domain to design tools, technology tools that is used for healthcare management or for disease management. And it simply tells you that for one to actually use a technology or a digital device, they must first of all see their perceived usefulness of this device and ease of use of this device. That will now inform their behavioral intention of using this device. And then if they now see that these two match, then they will now use the device. That was why I had to map it to this technology acceptance model. Then the interviews, like I said before, the target was to get 15 participants. Since it's a qualitative study, most times we get a limited amount of people. I invited 20 people, 17 responded at the end of the day. 10 interviews were decided to be conducted. Once saturation was reached, I decided to stop at the 9th participant. And these are kind of a summary of the questions that were being asked. It was categorized into 5 segments: preliminary questions, which was basically for demographics, then the current management guidelines, because if you want to use technology to manage a disease, you first of all have to know what is being done presently. Then now the third category was kind of wanting to know their knowledge about digital health technologies. The fourth one was their perception of how digital technologies could be used for self-care, self-management, and the recommendation for a specific digital device, which is aligned specifically to the Nigerian situation. Like colleagues have said yesterday and even today, we are talking about the 5P medicine, which is predictive, participatory, preventive, precisive or precision medicine. So we can see that people living with sickle cell disease, because they have to visit clinicians almost weekly or more than 2 or 3 times in a month, they need kind of a personal technology that can be able to assist them in assessing healthcare, if it is possible. So that was why we went into this research. So after I had done the interviews and I had to analyze the data. So first of all, these steps were used to analyze this data. I familiarized myself with the data by reading each transcript thoroughly. And then after reading them both in, one by one and across, I started generating themes within and across the transcripts. In the course of generating these themes, they were now mapped into patterns or structured into patterns, and then now formed teams. So from these teams were now modified stepwise, and after being modified, these teams are now reviewed the teams. Then after that, I refined the teams and then defined it and then got the names. So these steps are pretty much defined by Brown and Clark. So these are the kind of stepwise process which we use in qualitative data and thematic analysis. Well, it was both inductive thematic analysis, like I mentioned before, which was after this thematic analysis, I now mapped it to the technology acceptance model. So this is kind of a summary of the participants, their gender, their profession, location in Nigeria, their medical experience, as well as their experience with using digital technologies. Then the results, after doing this analysis, what were the results? First of all, before we can able to use digital technologies, I wanted to know their knowledge about digital health technologies. And mind you, digital health technologies are broad. So during this interview, I was able to kind of give them more knowledge of what digital technologies were. And in the process of doing that, I now found out that most of them already knew what digital technologies are, even though they were using it. So looking at this thematic tree, you can see that majority of them have good knowledge of digital technologies. Almost all of them have good knowledge. It's just some of them that have partial knowledge. Moving forward, the next theme that we got from the analysis, or that I got from the analysis, was perceived benefits of using digital health technologies to healthcare practitioners. So you can see the sub-themes here: improving work efficiency for healthcare practitioners. It saves them time. It makes work easy for them. It improves their doctor-to-patient communication. So, and it's also beneficial for data storage and sharing, online consultations, aids in disease management. I'm going to explain this further when I get this to the summary section. Then another section or theme that also came up during the analysis was the theme on perceived benefits of digital health technologies to the sickle cell patients themselves. We can see the thematic tree as well. Here, medication adherence, remote consultation, education about the disease, access to healthcare. Moving forward, the next theme also was on themes on barriers to digital health technologies adoption for sickle cell disease management. So in using every technology, there are always barriers. And one of these some of these barriers from these sub-teams, as we can see, is poor digital literacy, reduced doctor-to-patient relationship, like some of the doctors explained that those that are kind of adamant or they don't want to use, are resistant to using digital technologies. Definitely, it's a sub-Saharan Africa and less developed country, we have technical and infrastructural challenges. Here is a summary of all the four categories of themes that came out from these interviews or from this research. And here are the sub-themes that also came out from this research. Moving forward, from these results, we can see that at the end of the day, the doctors, their most recommendation or their perceived recommendation was, first of all, I want to say that this research is one of its kind, that it's the first that has been done to explore the use of digital health technologies for sickle cell disease management. No technology was found that was being used to manage this disease. And we can see from this doctor's perspective that they see a feasibility of using digital technologies in managing diseases. And the recommendation was that for you to use digital technologies, we should first of all look at the Nigerian situation. Many people in Nigeria use mobile phones, and we can leverage on this to get mobile apps that can be used for several functions, like for telemedicine, as you can see here, for symptom tracking, you know, kind of, you want to know your blood level since it's a blood disease, because when your blood level is low, you cannot be able to, you'll be affected by all these pain crises. Their second recommendation was pain prediction and management devices. So having a mobile app that can be able to predict your pain or manage this pain when you come into pain. So most patients, like, they wouldn't go to the hospital. You know, the way they react to, they are mostly reactive instead of preventative, you know. So most times they don't go to the hospital. So but if you can have a mobile app which they can use to track their daily, you know, activities, that way you can predict when pain crisis can occur, you know.
Gonna
And
interrupt you
you can
just for a
also,
second, Elvis. You got 2 minutes left for the presentation.
yeah, thank you for the reminder. So moving forward, we also have a research that has been done, but it was limited only to Kano State. So they recommended point-of-care digital diagnostic and monitoring devices. So we can see that this is kind of a third recommendation. This is like a tool that was used to collect blood. From there, the results are being transmitted through mobile phones and their digital records are being saved. That way, you know, we have an entire life cycle of digital devices that can be used to manage the disease. There was also kind of a mobile point of care or point of care digital diagnostic monitoring devices that was recommended by these practitioners or hematologists to manage sickle cell disease. And in conclusion, the study has demonstrated that digital devices are perceived to have that potential of helping patients as well as providers in managing their patients. And with the current infrastructural challenges in Nigeria, we can see that if we tailor these digital devices in the right way, patients living with these diseases can have better health outcomes. But for human-centered studies, as is being recommended for any digital devices, it is good to always expand our research to different regions as well as different patient groups. Recommendation here is to healthcare practitioners, to consumers, to the government, as well as to healthcare providers. To practitioners is for them to be able to convince their fellow colleagues to adopt digital devices for managing these diseases. For patients, if they leverage digital devices like this, they can be able to share knowledge among themselves on better ways to manage the disease from anywhere of the country or from anywhere of the globe. And then to the government, they can be able to use this research as a stepping stone to get information or how to be able to strategize, you know, to build infrastructures that will help in the development of such devices. While to digital health entrepreneurs, this research will be able to help them to be able to get information on the better or the type of digital devices that they can invest in for the global consumption. Here are some references, and thank you all for listening. If you have further questions or you want to get the abstract of this research, you can always scan this code, and I'm free for any questions and collaborations. Thank you.
Thank you very much for the wonderful presentation. Are there any questions? We'll start with those that are online in Zoom. So if you have any questions, you can turn on your microphone, raise your hand, and ask Elvis directly. After that, I'll take questions from the audience here in person. Looks like none from Zoom. Any questions from here about Elvis's presentation? Aside from how wonderfully he did his job and how excellent his presentation was, I do have one question for you, Elvis. You described some of the results of your analysis. What were some things that were covered, and maybe this wasn't covered in the interview, in terms of what was difficult or what challenges did different healthcare providers have when you talked about technology? Was it that they didn't know about it, or were there other issues that came up?
Well, the problem were sometimes the ones that are available, it's difficult to use due to the poor infrastructural technologies that we have in Nigeria. So like I mentioned before, it's a developing country. Of course, we have come far with digital infrastructures, but one of the problems is lack of electricity, which we all know that without electricity, you can't charge your phones, you can't use some of the laboratory information systems or EHRs in the hospital. So some of this difficulty they experience while they are using these digital health technologies. So another thing is also kind of poor digital literacy. So most of them are still not, they are kind of reluctant to adopt these tools due to the fact that there's really not enabling environment at the moment for adoption. Of course, a lot of them have it, but these challenges, it's what affects them while they are using it, because if they are kind of attending to patients, they have a lot of patients to attend to. And if these challenges comes up, it makes them adamant or resistant to using such digital technologies. And as well, some of them will tell you, I've been an experienced doctor in this field. Why would you tell me that technology can be able to, like clinical decision support systems or tools? How will you tell me that technology can be able to tell me what I'm going to do for my patients, you know. So these are some of the challenges that came up while having this discussion with them. If that answered your question, Oscar.
Yeah, that's great. Well, thank you very much again for the presentation. One more round of applause for Elvis. Thank you again.
Thank you all for listening.
And we'll turn it over to the next person in our presentation, or the next group rather. We have the title Revolutionizing Oral Care or Oral Health, through data science and artificial intelligence, a path to precision dental medicine and global well-being. So we have several people here. I don't know if anyone wants to take over. The first author that I see here is Nisha Daniel. Are you with us here?
Yes, Mr. Oscar.
Okay, wonderful. So if you have your presentation ready, you can share your screen. I'll put it up and you can begin when you're ready.
So good evening, ladies and gentlemen. I'm so delighted to be part of this DigiHealth Day celebrations in Germany, and especially by the European Federation for Medical Informatics. And I'm very highly esteemed to present my research work titled Revolutionizing Oral Health through Data Science and Artificial Intelligence, a path to precision dental medicine and global well-being. And the objective of this work is mainly to be part of World Health Organization's vision of universal health coverage for oral health for all individuals and communities by 2030, and also following the guiding principles of taking a public health approach to oral health and optimizing digital technologies for oral health. And let me introduce myself. I'm Dr. Nisha Daniel. I'm a dentist, and currently I'm a postgraduate student at the University of Edinburgh, Scotland, UK. Did you know that 1 in 2 people are affected by oral health diseases? And globally, 3.5 billion population are affected by oral health diseases. And it is recognized by the World Health Organization as the largest global non-communicable disease burden known. And for the evidence, it is the global oral health report given by WHO in 2022. It clearly shows how the oral diseases are the topping the number of diseases, be it low income, middle income, or high income economies. And what we perceive to be diabetes and cardiovascular diseases are far behind. So introducing my title, Oral Health, to define it, it is the state of the mouth, teeth, and orophacial structures that enables individuals to perform essential functions such as eating, breathing, and speaking. And also it has psychosocial dimensions like self-confidence, well-being. And it is a necessary precedent to cardiovascular health, safe pregnancy, child growth and development, and confidence. The increasing global burden of oral diseases and existing inequalities in the prevalence call for a newer approach to well-being as well as to scientific discovery, and that is data science in dentistry. So our work was based in a play school with almost 20 children between the age group of 3 to 5 years in North Chennai, and we deployed cluster sampling model. And it was also a free dental camp. It was done to check the oral health status of the people, and there was some adult population, so it was a probability sampling of that. A questionnaire in English was recorded, and we also received the informed consent of the participants. As the data collected was very minimal, we had to apply smooth technique, synthetic minority over sampling technique, and we used a software Veka for applying machine learning models. And this is the inequality disaggregated data analysis of the people who were who participated in the camp. So by gender, females were more than males, around 60%, and by age, less than 18 years of age was more. And by language, we had a very beautiful data set. People speaking Tamil, Hindi, Telugu, and Odia participated. And regarding the dental diseases by age, we can see from the spiderweb chart that the incidence of dental caries as well as the incidence of periodontal diseases. It was very high with the age group 50 to 60 years. It was very minimal at the age group 30 to 3 to 5 years. And we also collected data on the educational status of the participants. We have found that people who had professional education had higher level of treated caries compared to the other set of people. And as to Stephen Hawking saying, we need to apply wisdom to find out how to use the technology and where to use it. So we have tried to use supervised learning model. So we used 4 machine learning models with the data query. So first we applied random forest, the supervised learning technique. It has a greater tree diversity, and it also is overall better model. It has higher bias and lower variance. So as a result, our R value, that is the correlation coefficient, was 0.93, which was the maximum. And mean absolute error, MEAE value, was 0.3, and mean root relative square error, it was 34.75, which was relatively lower. And the second machine learning model we used was support vector machine. In 1992, Wapnick and co-workers have proposed this model, which is very good for classification, and is also often considered to be one of the best out-of-the-box classifiers. And when we applied our data, we were able to find the support vectors, like the R value was around 0.78 percentage, 78, and mean absolute error was 0.72. Root mean squared error was 0.8. And the third machine learning model was a linear regression, which is the most popular model. It shows a relationship between the independent variable and dependent variables. It's a very commonly used method for predictive analytics. And so when we applied the data, we found the R value to be 0.8%. Mean absolute error was 0.6, and root mean squared error was 0.8. And finally, we applied data to multi-layer perceptron. It's a type of artificial neural network, and it has layers one above the other. And when we applied this technique, we were able to get the R value as 0.8, and mean absolute error was 0.7, and root mean squared error was 0.9. And this is the data analysis led into the entire process. So we trained the data sets, the machine using the data sets we had, and we were able to find that overall random forest was able to provide very accurate prediction levels compared to other machine learning algorithms. And also it showed a higher value of R, or correlation coefficient, and lower values of mean absolute errors and RMSE. Yeah, so this is the result of the research work, and it was 93% correlation coefficient for random forest, the mean absolute error of 0.3, and the root mean squared error of 0.57, and which shows the definitive application of a random forest in predictive analytics of various oral health diseases. And we had some challenges while doing this work, mainly the data collection practices, about how we had collected the data and about the quality of the data we had received from the participants. And also there is a kind of training bias. Generally speaking, such research works, they have bias as to where this training will be used for self-care, or will it be commercialized. And also it involves patient safety, but this was a very non-invasive camp, and a non-invasive, it involved anonymous procedures, but still there are cybersecurity issues, and different geographies have different regulatory compliances. And so we have to adapt ourselves to WHO guidance on ethics and governance of AI for health, about protecting autonomy, well-being, human safety, explainability, transparency, and accountability, and also making AI that is more sustainable. So in conclusion, artificial intelligence, it poses to become the foundation for informed treatment planning in precision dental medicine when we are able to predict well and also uh, shortlist all the treatments that is for particular patient. And also when it comes to the population as such, it is very good for predictive analytics in population oral health and for oral health promotion, especially for self-care. Artificial intelligence is applicable and for making realistic methodologies for calculating preventable DALI index, which is a research gap in oral health. For oral conditions and overall oral health outcomes and oral health economics will be better. And author's recommendation is calibration of the data so that we can derive better precision dental medicine, and collaboration in research and innovation for seamless health care and delivery, and confidence to make health systems inclusive and free of bias. And that confidence reinstills and facilitates calibration more, and it's a cycle. And this can definitely lead to attaining UN Sustainable Development Goals. Like goal number 3, good health and well-being. Goal number 5, gender equality. 6, clean water and sanitation, which is actually a prerequisite for oral health. And 9, industry innovation infrastructure. And SDG goal number 13, which is climate action. So as a conclusion, I'd also like to quote Alvin Toffler's saying, that is, the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. And yeah, these are my references. Thank you. Thank you very much for your time.
Thank you very much for that presentation. So we have a few minutes. So if there are any questions, we'll start with people in Zoom. For those of you that are joining us virtually, if you have a microphone or want to type it into the chat, please let us know if you have any questions. I'll turn it over to the people in person in just a moment. Anyone here that has any questions for our esteemed doctor who just finished presenting? I have one clarifying question. Towards the end, one of the recommendations that you made was to keep an eye out on patient safety. You talked about this in the context of trying to empower or improve the, let's see, there we go. Yep. There we go. So what do you mean in this case by patient safety? Because if I understood your presentation correctly, you had this survey of the presence of oral disease with this sample size of 20 children. What do you mean by safety when you talk about challenges in this context?
Yes, thank you for the question, Mr. Oscar. The safety with respect to this particular dental experience, camp experience, is minimal. Because when we organized the camp along with the school principal and other organizers, we expected other adult population who might have issues of oral cancer or pre-malignant issues. So it is like we might be open to such infections also. Like as in when we are conducting a camp, we are not placing it in a surgical setup or on a clinic where we have all the sterilization protocols done. We are opening it in a school, which is a public place, and it does not have any of the protocol. We have minimal touch with the patient. So that is what I meant by patient safety. As in for this camp, it was not at all an issue because we did not. Most of the people were fine. It was like as in the trauma cases that came was also very minimal. But otherwise, generally these challenges, they are for any camp, I would say. Did I answer your question?
Yes, you did. Thank you very much. Then if we have no other questions, Let's see, we've got 2 more presentations left. We have one from Rupa. Are you here? Yes, wonderful. Then let me take this off the screen while we prepare for this.
Hello, good day to one and all present here. My name is Rupa Ramachandran, and I'm very happy to do this presentation today. It's on the topic assessing the knowledge and attitude towards 2D and 3D pharma printing technology among pharmacists in Regensburg, Germany. So I did this research in collaboration with another company called as Digital Health Systems. So they are currently involved in developing this 2D and 3D pharma technology machine. And they are in talks with health insurance companies, with pharmaceutical companies in order to launch the project. 3D printing technology in general helps to change a design into a physical object. Let's say, for example, I need a phone case for my phone. So I design this phone case in the laptop. I can feed it to the 3D machine, and then I can get the phone case like a physical object. So this is what 3D printing does. So 3D printing technology has been used in a lot of industry, for example, architecture, where they 3D print house models to show to the customers, and also in medical field, where they 3D print patient-specific anatomical models so that the surgeons can come up with personalized surgical plans, and also to teach the patients about their conditions, and also to improve medical education for students, and sometimes to customize surgical tools and prostheses. But when you look into the pharmaceutical sector, I think in the year 2015, USA was the first country to approve the first ever 3D printed drug called Ashpritam. This is used for epilepsy management. And after that, there was no other country which came up with 3D printing drugs. But when we look into the pharmaceutical sector, once again, all the drugs are mass produced. There is just limited dosage strength available for the patients. And it uses a technology that was invented 200 years ago. 200 years ago, exactly. So now recent studies have stated that one dose doesn't fit all. So for example, in UK, around 30% to 50% of the population, they benefit from this mass manufactured drug. And 7% of the hospital admissions are because of adverse drug reactions. So it's high time we think about personalizing drug dispensing too. So, and that's the solution, which is the 3D and the 2D printing technology. One of the advantages of this technology is that you can actually change the shape of the drug. You can add flavors and color to the drug, so it caters to the pediatric population. You can change the drug profile of the drug, and so on. So looking into the major stakeholders, it is going to be patients, it's going to be doctors, obviously, and it's going to be health insurance companies, which are going to reimburse for this drug cost. And also you have a lot of R&D companies which are working on developing this technology. And also you have pharmaceutical companies, you also have clinics, you also have universities, but the major stakeholder are going to be the pharmacists. So they are the ones who are going to be mediating between the patients and this technology. And that's why it's very important to assess their knowledge and attitude towards this technology. So when I looked into the existing literatures, so there was just one study that was done in UAE. It was done in the year 2021. Around 118 pharmacists participated in this study. So they had a very long structured questionnaire. It was around 32 questions. These two studies, they are not related to my study, but they are related to 3D printing. So this study was actually done among undergraduate and postgraduate nursing students. And this is more into the sector of food technology. So what I did was, I did this study in Regensburg. Regensburg has around 50 pharmacies. And of the 50, I was able to visit 18 because I had very limited time. And of the 18, 2 were permanently closed. And of the 16, 11 responded to this questionnaire. So this questionnaire had 3 sections. So it had only 13 questions because the pharmacists can easily, answer the questions when they are working. And this questionnaire was actually based on the previous study as well. And I also got some input from the company, which is the digital health system. So looking into the results, we have majority of the participants were females, and they were belong to the age group greater than 40 years and also had experienced more than 10 years. And when looking into the number of pharmacists working in the pharmacy, it ranged between 22 and 5. And when you look into the area of the pharmacy, it ranged between 235 meters square and 60 meters square. And when I questioned about whether they knew this technology in the pharmaceutical industry, only 3 answered as yes. And of the 3, 2, they knew it through the magazines and scientific reports, and 1 knew it through the university or the professor. And just 1 had seen the 2D and the 3D printing machine. So when I asked, how do they feel about this technology? It was good. 13 of them said it was neutral. They had a neutral feeling towards this technology. 3 said as good, and 1 said it as bad. When I questioned whether they are willing to know more about this technology, 50%, almost 50%, they said yes, and the other 50 said no. And there was just 1 person who was willing to attend workshops, which in the future. And when I asked whether they had any interest to purchase this kind of a machine in the future, nobody expressed any interest. And when I asked whether they had any sufficient space for the machine, just 3 responded as yes. And none of the participants knew any company that produced 2D and 3D printing technology. And I was a bit more curious. I thought maybe age and experience can actually be playing an important factor in gaining knowledge. But then I found out there's no association between age and experience and knowledge. And same with the willingness. I thought maybe people who are young, they were willing to know more about this technology, but then it proved to be wrong. So I was actually able to get similar results with the UAE study. In the UAE study, there was just 22% who knew about 2D and 3D technology in the pharmaceutical industry, whereas in my study, it was 16%. So it was almost similar. And they also found that designation and knowledge of this technology was not statistically significant. So that was also in my study. And the main source of information in the UAE study was through social networking and scientific conferences, whereas in my study, it was through scientific journals and magazines. And of course, my study had a lot of weaknesses because it had very small sample size. And not all pharmacists in the pharmacy, they were able to participate in my study because some of them were working, they had to attend to the patients, and some of them, they were not willing to participate in this survey. But one strength is that this is the first ever study that's done in Germany. So to conclude, overall, you get a perception of how pharmacists feel towards this technology. And in the future, for more research can be done in this field. I would say more qualitative research can give more answers to this. And I also shared my results with the company. So we are now planning to design a pamphlet to those who said they were willing to know more about the technology. So thank you so much. These are the references. And I would like to thank the company's director, Dr. Ukta Avaledu. She was helping me with the study, and also the Digital Health Day Scientific Committee and Professor Dr. Georgie Chaltikian for providing me the opportunity. Thank you so much.
Okay, we'll start just as we did before. We have a few minutes before the last presentation. Does anyone on Zoom have any questions about this latest presentation here?
Yes, please.
Go ahead.
Okay, so thank you for your nice presentation, Rupa. And I'd like to ask you that in the presentation, we have seen that almost 50% of the participants were not had the proper knowledge about this technology, and almost 50% of the participants didn't want to join any workshop in the future.
Yes.
So what do you think about the reason? Because we have seen that the age and the prior experience wasn't impact into this willingness or decision. So why do you think this is happening, that they are not willing to learn, or they are not that much interested in this technology? Thank you.
I think this technology is pretty new. It has not been introduced in Germany. I think only in the USA they have a proper working 2D and 3D machine. So I think once we start advertising for these for this technology, I think people will start knowing more. So that will actually pick their interest uh, towards learning this technology. So I think since this technology is very new, I don't. That's why I think they were not willing to participate in any of the workshops, or they were not they were not willing to know more about this. So I think one is to talk to do an advertising campaign to make sure that they knew this, and there should be more research articles also, so that they'll be able to read about it more.
Thank you so much, Rupa, again.
Thank you too.
Hello, I want to ask a question from Rupa.
Yeah, sure.
Rupa, I know I'm a pharmacist, and I know 3D and 2D printing for limbs, for the artificial printing of limbs,
Okay.
for people with disabilities.
Mhm.
But I want to know briefly about the other dosage forms of 3D and 2D printing, if you know any. Thank you.
There is, I think, one form called as polypill, where it has like more than one active ingredient. But then I recently read that the polypill is actually not as efficient as taking two medications. So that's the one thing that I know, but others, even I think I have to look into the literature.
Okay, thank you so much.
Thank you too.
Okay. Well, unlike the previous session, we're ahead on time. So we'll go into the final presentation here in just a moment. Okay. We'll start a few minutes early with the last presentation, and then we'll finish the session a little bit early. So I have the honor of presenting a research project that finished on campus not too long ago. So the program is called Sustain. It's part of DE, which is the German Academic Exchange Service in English. They have a program called the International Virtual Academic Collaboration. They've run this financing program 3 times. And as part of the 3rd round, the Sustain project, which stands for Summer School Digital Health Design, was created here on this campus. And I'll tell you a little bit more about that here. This is an international project that combines expertise and participants from 2 universities. The first one is the Deggendorf Institute of Technology, where we are all at, which is hosting this DigiHealth Day, and a partner university called the University of Agder. They are a university in the south of Norway. Agder is the province in the south. And so together, we had 2 project members. We have Professor Dr. Thomas Spittler. He's the program director of the Bachelor of Health Informatics program. He's the Vice Dean of this European Campus Rottal-Inn faculty, and he works on several research projects. This is an older picture of me. I am one of his researchers. I am doing a PhD right now with the University of Agder in Norway. I'm being supervised by Professor Dr. Santiago Martinez. He's part of the Health and Nursing Sciences faculty at this university, and our other project partner from the University of Agder, which is Professor Dr. Martin Gerdes. He is from the Information and Communication Technology faculty. So this is an international collaborative project that was financed directly from the Federal Ministry of Education and Research through the cooperation with the German Academic Exchange Service. Basically, the way that this program works is that it is an international university cooperation program. The goal of this was to bring two universities together and try to create a program or create a teaching opportunity that can include students from different programs in different universities in different countries. So the key is that this was an international or cross-border university cooperation, not something within a singular country. The goal was to encourage worldwide mobility. It could have been this university, it could have been in any other university in other countries. This is just the partner that we had. There was an emphasis on digital learning and working because mobility, as we've seen after the COVID-19 pandemic, is at least largely able to be done digitally. And the way that this project worked was breaking it down into 5 steps, starting by creating the team to prepare some content, embedding all of the themes within the curriculums of all of the faculties involved, engaging students and instructors, creating a virtual teaching format, and finally building this community of practice. So this is the flyer that we sent out here, which covers the main topics that were included within Sustain. It was hosted as a virtual summer school. This means that rather than a traditional course that happens weekly or in a couple of blocks, this was an intensive week. It was 1 week long from the 7th of August until the 11th. And unlike many other curriculums, this was actually a project-based curriculum. That means that rather than just saying, we're going to be learning through this content, you'll have an exam at the end of it, it was instead framed as a problem that students work together on in groups to try and solve by the end of the week. We had an emphasis on nursing. Professor Dr. Santiago Martinez, he's in the nursing faculty, and so part of the overlap in the curriculum was to be able to address some of the challenges in nursing and take a look at some of the digital health technologies that might be relevant. So we looked at 3 areas within nursing: telenursing, digital nursing education, and facilitative technologies. And as far as the actual information, the themes and the concepts that were covered, we had 4 major conceptual themes that were each represented by the project partners. I provided the expertise for digital health literacy and equitable healthcare access. Professor Dr. Thomas Spittler, he provided the knowledge on health and sensor technologies, more on the hardware side of things. Professor Dr. Martin Gerdes, he from the ICT faculty, provided much more information about networking and implementing these digital solutions. And Professor Martinez is an expert on ICT and e-health solution design, particularly for nursing. So more about the usability and more about how to make it easier for people to use these different technologies. So at the end, the way that we formed it out, each of these 4 topics had their own dedicated teaching day. And on top of that teaching, there was time dedicated for students to be able to actually work on creating a prototype for a digital health solution. You've heard probably in the morning plenary session, and you've heard from some of the presentations today, digital health solutions can take many shapes and forms, sometimes more useful, sometimes more expensive, and there's a lot of talk. In this particular project, we were focused on the usability of it, how to take an idea and say, what could this look like in real life? And so for the summer school, you had 4 days of intensive learning, 4 days of working together with the instructors, working in groups, and presenting a feasible prototype by the end of it. Before getting into the results, a big part of this program was the teaching. The way that teaching was set up, this was a virtual summer school. So we hosted it much in the same way as we're doing now over Zoom. Zoom was the easiest way to get mobility for all participants involved. So we had several Zoom sessions. We had some sessions that were live. This is a screenshot from Professor Spittler. He was not able to join live, but he pre-recorded some content for the students. And across these different teaching sessions, it wasn't just the traditional lecture style. We worked on building content together. And so we used the Moodle platform, which is what iLearn is hosted on, where each day had its own dedicated content. There were supplementary materials. and we offered exercises and feedback sessions for all of the summer school participants. Now, the goal behind Sustain was to be able to develop a prototype for a digital health solution, but not just come up with an idea and create something with it. We started with 4 defined criteria, so they needed to meet a minimum of 4 categories of information. Students were split into groups where each one of them went through a case study. This is a case study that was published out of Australia in 2008. So a clinical nurse put together a total of, I think it was 18 different case studies. Students split into 2 groups that each selected their case study. And through a series of lectures, discussions, some collaborative working sessions and different tools, they worked together to generate a prototype for what they thought would be the best digital health solution to solve the problem that their group was tasked with. So we have group number 1. For group number 1, they had what was called Ruth's story, an active yet uneasy partnership. This describes Ruth, which is a 61-year-old Australian woman. And without going into a lot of detail, she has a pretty detailed healthcare routine. She's got a couple of chronic diseases, and managing it is a little bit tough for her. So what group 1 did was they started by creating a persona. This is, so after reading through all the different pages and discussing it amongst one another, they created a visual persona of what Ruth or similar people to Ruth could look like. The information from this was then used to create a basic idea of what the main features of the solution would look like. In this case, the 3 main features for group 1 was to create a medication plan, to set up a mood diary, and to look at a history of the different healthcare encounters. Now, this took the form of a mobile application, and what you're seeing here on the right side of the screen are a couple of the different screens for a few of these features. The mood diary is displayed here through a data visualization section. You can break it down into Ruth's mental health, even show how the mood entry would actually be created. So there was some level of detail. We used what is called Figma, which is an online free-to-use prototyping tool. And group 1 decided that they wanted to stick with smartphones. Group 2 had a different case study and took a slightly different approach. Group 2 was tasked with Alan's story, opting out of the health service merry-go-round. In this case, you have Alan, who's a little bit younger. He's a 57-year-old pensioner, but because of his very complex set of comorbid chronic diseases, he has a lot of problems trying to take care of himself because he doesn't know so many people where he lives in Australia. Here's the persona that group 2 created with Alan, his location, what his employment status looks like. He is divorced, he doesn't have kids. It's very difficult for him to find, not necessarily find healthcare resources, but it's very challenging for him to not just pay for them, but believe that it's even worthwhile, because his physicians make recommendations, but he doesn't know if they're really necessary or even if he has the money for it. Unlike group 1, group 2 came up with a tablet-based solution. So not something that is in anyone's pocket necessarily, but they decided on a tablet. It's a little bit bigger, probably easier for Alan to see. And this tablet was designed to, in a very similar way, try to help him get a bit more organized. You have this calendar app that was included as part of one of the major features. Even this active reminder, not just putting a notification, hey, don't forget to take your medication, but to have a personalized avatar to try to get a little bit more of a human connection with Alan. And finally, a way for him to try to reduce the symptoms of some of his different chronic diseases by providing nutritional and physical activity recommendations. So aside from the actual results of what the students came up with, What was interesting for us through Sustain was to see, was it successful? Did we actually achieve our goals, or what was the experience of the different individuals that participated in the study program? Not study program, summer school. So we had 50 registered students across the board. In terms of study level, we had just about a fifth of the students were on the bachelor level, and the overwhelming majority were on the master's level or above. And for this specific faculty, so the European Campus Rottal-Inn of the Deggendorf Institute of Technology, the majority of participants came from the Master Global Public Health Study program. That was followed by the Bachelor Health Informatics, Master Digital Health, and then the Masters of Artificial Intelligence. We structured our results into two categories. The first one is, what were the digital literacy learning objectives? So what were their experience with using digital technology? What was their experience learning? When asked, how confident do you feel about your ability to find high quality scientific evidence? You'll see the pre-scores on the left and the post scores on the right. Just under half of the participants felt confident. The rest of, or the majority of the rest of them felt relatively unsure, with some people feeling very confident. However, afterwards, we saw a very sharp increase in the confidence of these students and their ability to find scientific evidence. When we looked at e-learning tools rather than just high-quality scientific evidence, we saw that similarly, about half of the participants felt relatively confident or very confident, whereas afterwards we saw that the vast majority, so just over 90% between very confident and confident after using some of the different applications and tools that we used. When it came to actually using these e-learning tools, most were confident or very confident before the program. And that group of very confident we saw increase dramatically. Because high quality scientific evidence is necessary not only to formulate an idea and a methodology, but also to inform the information that goes into developing a solution, we asked how confident our students felt. Beforehand, about a third of the students felt very confident, just about half of them felt relatively confident. And afterwards, we had less than 15% of students that didn't feel confident about using some of the information and the types of evidence that you can find. And finally, kind of coming back to the student perspective, yes, this is very helpful and it can be interesting for the future professional careers, but coming back to everyday life, how useful did they feel that the internet was when it comes to making decisions about their own health? Previously, maybe about half of them, just under half, felt like, yes, it could be useful. And then afterwards, we found that all of the participants that finished the survey, they found that information to be at least useful or very useful. Because this was an international collaboration, alongside the fact that this faculty is international, there was a lot of intercultural and cross-cultural collaboration. There's a couple of different measures of cultural intelligence that we used. When it came to metacognition, represented by I check the accuracy of my cultural knowledge as I interact with people from different cultures, we saw a relatively wide spread of different comfort levels before participating, but afterwards, the majority agreed or strongly agreed. Even in a different domain of cognitive intelligence, checking the accuracy of cultural knowledge as interacting with people with different cultures, about half of them felt neutral, and then there was a wide range of agreeing or disagreeing, whereas afterwards, significantly more, at least partially agreed, which suggests that they felt more comfortable with checking, hey, does this information that I know about someone from this culture, from this region or this country, does that actually fit? Even when it came to interacting with others from different cultures, we found only a slight change, people were already at least going into it somewhat open, and we found just a very slight increase in agreement with that statement. Finally, in the behavioral cultural intelligence represented by I change my nonverbal behavior when a cross-cultural situation requires it, we had a wide range ahead of time, whereas after we see the majority would agree or strongly agree that they make these adaptations, that they make these changes. So what these findings showed to us was that this was interesting. We did find, and I'll go back here in just a second, we did have some creative ideas, and we did have ways for students to actually apply these different knowledges, whether it was a tablet-based intervention or a smartphone-based intervention. Even their experience through it was almost overwhelmingly positive by most measures that we collected. So the takeaway here is that coordinating between different university calendars is a bit challenging. They have a different timing for their semester system that we do. We were unfortunately unable to offer ECTS, so we were not able to offer credits for participants, which is something that we'd want to do if we continue in the future. We want to have more guidance. We had 4 partners, 2 from each university, but further guidance would help us grow this program or get some more depth. And one of the goals is to take this kind of approach and take these ideas and offer them as potential bachelor or master level thesis from students for both universities. And that's it. If you have any questions, you're welcome to ask. Thank you very much. I'll start with Zoom. Anyone on Zoom have any questions about this project or this presentation? All right. Anyone here in person? Questions? Yes. Hello. So the question for those that couldn't hear it on Zoom, for those people that are in health backgrounds or not so much in technological backgrounds, can they access this? I'll have to check up on that. I need to check with the founders to see if that's the funders to see if that's allowed. We have the information for those that registered and they can review it, but after this presentation, I'll leave a paper out. You can put your email address, and then once I find out that information, I can let you know. Very welcome. Any other questions? Yes. Are you talking about in general, or are you talking about this project? So the question is, if you have a topic, do you need to do a literature review or do you need to go out into the fields? Most times you'll need to do a little bit of both. Every research needs to have a literature review. Some research designs, you do need to collect data yourself from talking to people. Sometimes you can collect surveys, but you need to have some kind of observation is the word. Yeah, so you need to somehow collect new information. It doesn't mean that you have to go out into the field, but you have to somehow collect that new information. Any other questions? None on Zoom? All right, so that ends the young scientists session, I believe. If you want to ask me anything, I'll be around for the next 10 minutes, but this session is over. And as far as DigiHealth Day goes, we're going into the lunch break after this. So keep an eye on what sessions are coming up in the afternoon and enjoy. Looking forward to see you later.